For the introduction. Breast cancer is the most commonly diagnosed cancer in women. In Egypt, it accounts for almost 33% of all female cancers. Quite simply, early detection will mean an improved survival. Even though mammography, the cornerstones of breast detection is self-breast examination, clinical breast examination, mammography, and ultrasound. And even though mammography remains the mainstay of breast cancer screening, 10 to 15% of all palpable breast cancers are not detectable with mammography, and its sensitivity decreases in younger patients and those with increased breast density. MRI plays an important role in the diagnosis of breast cancer, and some of its indications are inconclusive findings on conventional imaging, staging newly diagnosed breast carcinoma, lobular cancer staging, unknown causes of axillary adenopathy, evaluation of neoadjuvant chemotherapy, exclusion of post-operative local recurrence, silicone implant rupture, and screening in high-risk patients. In a quick comparison between the three modalities, you will find that mammography has a specificity of 99%, and MRI ranks the highest in sensitivity with 100%. In order to achieve a full diagnosis, biopsy from the lesion is very important. And since the development of breast biopsy coils, MRI-guided percutaneous starch core or vacuum-assisted needle biopsy has become available in some selected centers with success. In tissue diagnosis, the role of MRI evolves around lesions that are neither palpable nor visible on conventional imaging techniques. And even though sometimes a second-look ultrasound can help detect these lesions, still some lesions will remain undetectable. And that is why it is important to have the possibility of performing MRI-guided biopsies and localizations. MRI has some inherent properties that makes it beneficial in intervention, and these include its ability to elicit different tissue characteristics, its soft tissue contrast and exquisite anatomical detail, its multiplanar capabilities, its ability to visualize vessels without using intravenous contrast, and its ability to monitor the effects of percutaneous therapies during a procedure. However, before embarking on a biopsy, there are some important considerations that we have to think about. One of these is whether to use an open or a closed magnet. With open magnets, we have access to the breast from all angles. We have interactive real-time visualization of the needle, which allows the freehand approach. However, with closed magnets, we have a wider availability, a higher field strength, better field homogeneity, and the grid system can be used. Another thing to consider before an MRI biopsy is the needle. High magnetic fields prohibit use of the conventional ferromagnetic needles, and that is why a balance has to be struck between a needle that is both MRI safe and that causes the least artifacts. And that is why materials containing increased nickel content or titanium have been found to work best. Another thing to put at the back of our minds is even though artifacts can be bothersome, a controlled artifact can help us actually locate the wire or needle. This picture shows an enhancing lesion and the needle beside it. These are the equipment that are used during the biopsy. This is the breast coil for which the breast is placed. The compression plate, the grid, and the needle guide and the fiducial marker all help to localize the lesion. A fiducial marker is usually an a vial filled with gadolinium or vitamin E marker that can help us localize the lesion. And this is what it looks like when it's fully assembled. Another thing to consider is breast immobilization, which is important for several reasons. One, as the procedure progresses, the lesion will actually start using some of its contrast, and the surrounding parenchyma will gain contrast. So it helps and the lesion will lose its conspicuity. That's what with the immobilization, it will help to maintain. Immobilization actually help maintain the lesion, and it will help minimize lesion motion during needle placement. Another thing, it enables the entire breast to be imaged with fewer sagittal slides, thus shortening the procedure time. However, too much compression can interfere with lesion enhancement and visualization. The biopsy procedure includes having the patient prepared first, which includes getting an informed consent, getting the history and vital signs, having a cannula in place, and deciding whether you want the patient positioned in a prone or supine position. With the prone position, you can allow the use of breast coils, and the breasts will be away from the chest wall. The biopsy procedure involves placing the breasts in the breast coil. This is at the grid with the vitamin E marker taped onto the skin of the patient. This is an MRI before the start of the procedure to show the lesion. This is after the placement of the grid. This shows the patient preparation. And this is actually the placement of the needle through the needle guide. And this again shows the enhancing lesion with the needle placed. As with other conventional methods, we have the 4 types of tissue sampling, which include fine needle aspiration cytology. This is the least invasive procedure, but also the one fraught with the most error. It's technically successful in 61 to 100% of the cases, with a cancer yield ranging from 11 to 50%. Its major disadvantage is insufficient sampling. It has been widely replaced now by core needle biopsy. Core needle biopsy allows larger samples, which improve the accuracy of the results and allow post-biopsy marker to be placed. Its advantages over wire localization are decreased invasiveness, morbidity, and cost. And a 14-gauge automated needle often underestimates the pathology of DCIS or atypical ductal hyperplasia, which makes this a disadvantage. Wire localization is still the mainstay of MRI-guided intervention. Large surgical specimens reduce the sampling error and compensate for some inaccuracy of needle placement. A disadvantage, however, is higher morbidity and financial cost compared to minimally invasive procedures such as core needle or vacuum-assisted breast biopsy. Finally, with vacuum-assisted breast biopsy, when you compare the core needle to it, a 14-gauge core needle device collects 17 milligrams of tissue. An 11-gauge vacuum-assisted breast biopsy device collects 100, while a 9-gauge collects 200. It allows accurate targeting of lesions smaller than 10 millimeters and can reduce the high risk and DCIS and underestimate rates and the miss rate compared with large core needle biopsy. However, its cost is higher than those with large core needle biopsy. This picture compares the 14-gauge with the 11-gauge acquisition chambers. This shows the MRI-compatible needle and wire combinations. And this picture shows the vacuum-assisted biopsy handpiece. This is the sampling notch and the biopsy device. Advantages of MRI-guided biopsy include: can be performed on an outpatient basis, it's more cost-effective than surgical biopsy, it's less invasive than surgery, thus there's a less risk to the patient, and accuracy is comparable to a surgical biopsy. There's less scarring with minimal recovery time. The disadvantages are: other modality-guided interventions may be even more cost-effective, limited number of facilities are equipped to perform the MRI-guided biopsies, it's not suitable for claustrophobic patients, and small lesions or lesions located near the chest wall tend to pose the largest challenge because they are more difficult to target. As is seen in this picture, the needle is actually placed outside the grid. A surgical biopsy may still be performed if the results are inconclusive or if an adequate sample was not obtained. Complications include hematomas requiring drainage, excessive bleeding, infection, and injuries such as lung collapse. The possibility of a long procedure time and therefore a high cost is still there. MRI can play a role in the treatment of breast cancer, and that evolves around the cancers that are not. It plays a role in the treatment of breast cancer, and it's as seen nowadays, there's usually a trend towards less invasive methods. And one of these methods is the ablation, which is the direct application of a chemical or thermal therapy to a specific focal tumor or tumors in an attempt to achieve eradication or substantial tumor destruction. Types of ablations are chemical or thermal. Thermal includes radiofrequency, laser, cryoablation, and high-intensity focused ultrasound. Chemical ablation has not been yet used in the treatment of breast cancer. Radiofrequency ablation is a non-surgical technique that provides a cosmetically pleasing result. Because of the high-frequency alternating current that's used with MRI is not actually used in the actual procedure, but it can be used for the needle localization before and reliable treatment response evaluation after onset of the alternating current. It is better than ultrasound in that it allows accurate disease estimation and thermal mapping of the procedure. This picture shows the MRI scans of a successful radiofrequency ablation. This is the irregular enhancing lesion before. And here, post the radiofrequency ablation, you can see that the tumor is no longer enhancing. It is emerging as a promising treatment for breast cancer, and studies show that for it to be effective at ablation with few complications or adverse effects. However, further research and refinement of the procedure before being offered as a therapeutic alternative to surgical excision for ocular breast cancer is needed. With laser ablation, we have light energy applied, and several studies have shown that small tumors can be ablated with negative margins. However, it still shows inferior results compared to surgery. Another form is cryoablation, which is the destruction of breast by the application of low temperature freezing. Using MRI, frozen tissue may be very easily delineated from surrounding structures in all 3 dimensions. This is a picture showing the ice bone, or the probe that is used. It is superior to ultrasound, where the lesion can be obscured by posterior enhancement of the ice bone. An advantage of cryoablation is that the code itself requires some anesthesia, and it has been approved by the FDA for the ablation of benign fibroadenoma. For early stage breast cancer, tumors that are less than 10 to 15 millimeters, cryotherapy is promising. This shows the pre, per, and post-ablation pictures. At the right, the residual ice ball and dead tumor are seen 1 month later. Finally, the high-intensity focused ultrasound. With the previous 3 types of ablation procedures, they all require transcutaneous insertion. However, the high-intensity focused ultrasound is non-invasive, and it focuses around the ultrasound energy is focused into around a small tissue surface, a small volume, as you can see here. And its non-invasive nature and controlling the treatment real-time via MRI imaging mean that it is the front-runner of ablative breast cancer therapies. To date, several small trials have proven it to be safe, but efficacy has ranged widely from 43 to 100%. If ongoing studies find it to be equivalent to breast-conserving surgery, then it will become the breast cancer treatment of choice for appropriately selected patients. There are currently 3 significant obstacles to that. One is the long treatment time. However, with advances in technology, this will be overcome. Another is the uncertainty of margins. But as with the use of surgery, when we have a multimodality care, this could also be an overcome problem. And finally, due to post-ablation fat necrosis resulting in significant anxiety to both patient and surgeon and obscuring any local recurrence, this can be a problem, which can be overcome by careful monitoring or by surgical removal of the mass itself. MRI sensitivity to temperature change that is not found in any other imaging modality makes it the perfect choice in guiding thermal ablation. This is the thermal map that we can see by the use of the MRI, and this is the tumor after the ablation has been done. It is also the most accurate imaging modality for visualization and delineation of breast tumor margins in 3 dimensions. It can therefore be used in planning, targeting, monitoring, controlling, and follow-up after image-guided ablative treatment. In conclusion, the major defense against fighting breast cancer is its early detection. While mammography is the main screening tool, there still remains certain indications where MRI has proved irreplaceable. The increasing use of MRI necessitates the need for MRI-guided biopsy in order to reach a full diagnosis. There is an increasing trend towards treatment of breast cancer by using minimally invasive procedures. The MRI sensitivity to temperature change makes it ideal in the monitoring and control of several ablative procedures. The success of several trials highlights the possible implementation of such procedures in the future. Just like to end up this with a video that will better demonstrate This step shows that clips are performed at the end of the biopsy. Thank you.
Thank you, Dr. Sherian, for your very nice talk. Any questions? أي أسئلة؟ طيب دكتور
Sherihan, you tackled many issues actually, and all they need 1 hour for everybody to understand. But I have two really comments that you confused me a bit. First, you said something about the application of the open MRI and the closed MRI in examining the breast and in interventional techniques. So my question, the first one is, do we use open MRI for MRI of the breast and for the interventional techniques as well, or this is limited only to the closed system?
No, I was actually thought there's the option of either using the open or the closed, especially with the biopsy, because it will save a lot of time and to allow the radiologist to have a freehand approach with the open one. The closed one will take a longer time, as the patient will have to move in and out of the machine several times, and it would require the use of a grid as was shown. So I think it will depend upon the availability of either.
So you're talking about the intervention and only for the open,
maybe,
no?
Or the intervention.
Yeah, so for non-radiologists who are attending here, breast imaging using MRI is only for the closed system, the high field, starting from 1.5 till whatever it's coming. So, but for interventional, that's what the slide meant for you. That's only for the interventional, which is still not widely available, as you mentioned. Yeah. A second issue is that you mentioned something about higher morbidity with the MRI needle biopsies compared to the vacuum-assisted biopsies. Why is that?
Higher morbidity?
Yes, you mentioned that in one of the slides, in the earlier slide. I'm sure it was not meant to be like that. It's no really difference between the morbidity of either systems, right? You agree with me?
Yes, I agree.
Okay. So this is just for the start. I think Dr. Nagla wanted to ask a question.
Just a comment. I want to just to clarify, when we speak about MRI of the breast, it should be high field. Most of the high field are closed system, and when they refer to the open system, it's for the high field open system. There are available 1 Tesla with open field, not to send around message that we can do biopsy on the low field magnet like 0.3 Tesla or so.
Any other questions? طيب هو دكتورة شيرين، بس أنا عايز أسألك بالنسبة للأبليشن. أنت ما قلتلناش إيه الإنديكيشنز بتاعت الأبليشنز في البريست؟ يعني إمتى أعمل أبليشن للبريست؟
هو لسه برضه مفيش جايد لاينز محدده قوي، بس هو اخر ستاديز معموله انها ممكن تبقى مثلا in older patients اللي they can't undergo surgery. ممكن تبقى lesions that are small، بس كل ده لسه most of them are under trial، يعني مفيش specific guidelines that have yet been established.
طب احنا نسأل الدكتور وحيد بيه بقى. هل حضرتك هتسمح للابليشن انه يكون ليه رول في البريست؟
لسه بتكلم
يعني هي قالت لنا لسه طويله من التايبس اوف ابليشن.
عندنا فعلا جروب بيشنتس
ممكن دقيقه واحده.
As you know, in all types of surgery, you have group of patients that we cannot go for surgery as the primary treatment, and the surgery still, or ablation or excision is still the primary treatment. And عندنا مثلا عيانين very old age, cardiac patients, patient with very small lesions that can be eradicated completely. And if you remember, we tried about 15 years ago to have a protocol for management of such lesions by radiofrequency ablation in MCI at that time. And I think with time this will be one of the issues that will be added to the management of certain groups of patients with breast cancer. As even sometimes we look for palliation, for some sort of palliation or some sort of local excision without going to the axilla in high-risk cancer patients. And this is recommended worldwide now. Or very high-risk patients, we can discuss this within clinical trials, of course, to take certain group of patients who are high risk and we cannot go for surgery to try to do this type of treatment.
طب احنا نحب نبقى نعمل شغل في الموضوع ده يعني ونشوف ايه الريزلتس بتاعته.
يا ريت نعمل مجموعه مش من المعهد بس، من مصر كلها، وتبقى ترايل يعني للعيانين اللي هم مش هيعملوا جراحه. يعني ما فيش حد ساعتها هيقدر يقول ان العيان ده اي كان دو سيرجري فور هيم وانت ليه عملته. وبعدين انا اعتقد ان يعني we can go in parallel مع العالم كله في اي حاجه زي كده. why we will wait until we have the results to be published and established and then we will go even if it's going to fail after that. why not to try.
هو ممكن في اللوكالي ادفانسد بريست كانسر اللي هي بتبقى تريتد نيو ادجوفنت كيموثيرابي، بتقعد تاخد كميات يعني او هرمونال تريتمنت في الاولد ايجنج، ما لهمش اي لاين اوف تريتمنت تاني للميتاستاتيك بيشنت كطريقه للديبالكينج. يعني هو ده الانديكيشن الناجح سواء للكرايو ولا الراديو فريكونسي. الراديو فريكونسي عندها مشكله انه البريست مش الاورجن السيوتابل فور الراديو فريكونسي عشان البيرن والمشاكل بتاعه الهيب، لكن الكرايو ابليشن ممكن يبقى بروميسنج بالذات في ان احنا نعمل زي تيومر ديبالكينج من غير ما يحتاجوا ياخدوا كل كميات الدواء او الكيموثيرابي اللي بياخدوه.
هو what about nanonite? You have the machine.
ايوه انا كنت هقول اهو.
We are waiting for that. We'll have one in the surgery department very soon.
يعني عندنا جهاز الحمد لله.
فاحنا we can share you in the same machine. We can recently 1 week ago I have some people from Croatia and I think from Romania. They have very good results in treating of malignant melanoma, the transit lesions between the primary lesion and the metastatic lymph nodes, with very, very good results and very good survival until now. So we have many fields, this type of local ablation that can be applied in any other lesion. In pancreas also in Italy, they have very good results using the nanoknife. In carcinoma of the head of pancreas, body of pancreas, they have very good results until now.
احنا عملنا حوالي 10 حالات بانكرياس. الدكتور اشرف عنده سؤال.
Actually بس كومنت ان احنا الابليشن يمكن الراديو فريكونسي ذات وات وي ستارتد في الناشونال انستيتيوت اتعمل شغل، وعندنا في القصر العيني برضه عملنا شغل. وورلد وايد the results were not that encouraging, and the literature states that it has a very limited role في التريتمنج اوف كانسر زي ما حضرتك اشرت، بالذات في الناس اللي هم unfit for any other type of treatment. الجديد دلوقتي اللي بيتكلموا عليه الهاي انتنسيتي فوكس التراساوند، وده لسه very early لسه في الريسيرش بتاعه، انما وجهاز غالي جدا. انما برضه واي نوت ان احنا لو في possibility ان احنا نبتدي نعمل يعني 500 يبقى كويس قوي. نبتدي نعمل يعني نبتدي الريسيرش بتاعنا، ونبقى حتى انا دايما بقول زي ما حضرتك اشرت ان ممكن الريسيرش في الاخر الكونكلوجن انه لا ما ينفعش، يعني واي نوت بس ده كونكلوجن.
العالم كله بيعمل كده.
يعني thank you very much. Any further questions? Anyhow, the next speaker is our famous Professor Mahalal, and she's going to present to us here contrast-enhanced spectral mammography versus ultrasound in differentiating breast lesions. Dr. Maha Hilal actually has got two presentations, but هي عشان الوقت وكده هتحاول ان هي يعني تكتفي بواحده وهتقول هنت على الثانيه في الوسط يعني.